Good evening, friends online. This is Dr. Wang Ming from Shenzhen University General Hospital. Thank you all for your continued support and encouragement for extrathoracic surgery nets. Today is our expert connection. Surgical explanation live issue 13. I am very fortunate to invite Professor Li Yong, Cancer Hospital, Chinese Academy of Medical Sciences. Tell us about thoracic laparoscopic radical esophageal cancer surgery. Posterior sternal approach cervical anastomosis. That's the video of the McEwen surgery. The highlight of the surgery was the manual anastomosis of the posterior sternal path. Response to subclavian artery hemorrhage. Isolation of tumors invading the trachea. And standardized dissection of mediastinal lymph nodes. Let me briefly introduce Professor Li Yong. Professor Li is the founder of the official account Esophageal Forever Talk. National Cancer Center Cancer Hospital, Chinese Academy of Medical Sciences. Chief Thoracic Surgeon, Chiba University, Duke University. Visiting scholar at MD Anderson Medical Hospital, North Carolina Central University. Postdoctoral fellow at the Institute of Biomedical Science and Technology. Deputy Chairperson and Secretary General of the Integrated Esophageal Cancer Committee of the Chinese Anti-Cancer Association. Deputy Chairperson of the Science Popularization Committee of the Chinese Anti-Cancer Association. Standing Committee of the Esophageal Cancer Committee of the Chinese Anti-Cancer Association. North Carolina Chinese scholars. The founder and first president of the China's Exchange Association. He has published nearly 100 papers in domestic and foreign journals. Presided over more than 10 provincial and ministerial projects of the National Nature Fund. More than 30 national patents. Participated in and developed a number of diagnostic and treatment guidelines and norms. It has a high reputation and influence in the industry. The interactive guest is Professor Lu Xiui. Professor Lu is Chief Physician of General Thoracic Surgery, the first affiliated hospital of Zhejiang University School of Medicine. Doctoral Supervisor. Party Branch Secretary of General Thoracic Surgery of Zhejiang University Hospital. Member of Thoracic Surgery Branch of Zhejiang Medical Association. Zhejiang Medical Association Thoracic Surgeons Branch Member. Member of the Special Committee for Rapid Recovery After Cancer Operation of the Chinese Anti-Cancer Association. Welcome to the live stream bullet comments and Thoracic Surgery Network WeChat group interaction. Ask questions and provide valuable feedback. Then please give a brief introduction to Professor Lu Xiui. Then Professor Li will explain the PPT. Today, it is a great honor to invite Professor Li Yong to explain to us the operation of these surgeries related to esophageal cancer. Professor Li Yong has a WeChat official account called Esophageal Yongtan. Very well done. It is a knowledge base for modular and standardized esophageal surgery operations. There's a lot of content in there. Professor Li has spent a lot of time and energy on this. The content I saw was very carefully edited and produced. There are various surgical procedures in the very system. There are also various clinical situations encountered. There's some wonderful standardized processes. For us young doctors and for people like me, I can already do my own surgery. But I still get a lot of knowledge out of it. Learn a lot of new things. Therefore, I have great admiration for the work done by Professor Li. Learn from Professor Li, and today is also very honored to have this opportunity. Be able to communicate directly with Professor Li online. Then we have Professor Li Yong to explain today's content. Then I highly recommend you have the opportunity to search for Esophageal Everlasting Talk on your mobile phone. Take a look at Professor Li's WeChat official account. Really full of dry goods and can learn a lot. Hello, Professor Li Yong, please. Thank you Professors Wang and Lu for their introductions. I would also like to express my special thanks to the two professors for their recognition of Esophageal Forever Talk. It shows that our efforts to do Esophageal Talk forever are valuable. We are still very happy. I was also very fortunate to go to the Thoracic Surgery Network today. Let me tell you about our surgery. Then this introduction, mainly from the overall situation. There are also some special cases. He combined the situation of several patients. Let's introduce it to everyone together. Today I will first introduce the case of this surgery. This patient was diagnosed with esophageal squamous cell carcinoma for more than 5 months. 4 cycles of neoadjuvant chemotherapy. Then his lesion is 27-30 cm from the incisor. There was no lymph node metastasis on the preoperative PET-CT. Then our clinical stage is 3 We do thoracic laparoscopic surgery. Esophagectomy with 3 incisions and left neck anastomosis. Here's a comparison of the patient's tumor before and after neoadjuvant therapy. So the relief is still good. Operate from the chest and neck. Introduced to you separately. So the first thing we do is we do the chest operation. The patient lies on the left side. It's that we have 4 poke cards. Generally, we choose 4,679. Sometimes I also choose 3,679. That's something you're all very familiar with. During chest operation. First, I wanted to call for a total excision of the membrane. We are going to remove the mediastinal membranes on both sides of the esophagus. The lymph nodes need to be completely dissected, including the 106 pull group, which is more difficult to clean. Do all the cleaning. In addition, it is modular, so the process is very fixed. It's very handy. In addition, on some detailed operations, we've come up with a few tips. I will share with you later in combination with the surgery. For example, like the two-way method, there is also the left recurrent laryngeal nerve, which is difficult for us to free. First of all, it's prone to damage. Second, easy to remain. So how can we do it well, quickly and safely? Lymph nodes adjacent to the left recurrent laryngeal nerve dissected. So we've come up with a two-way street. That's easy to bleed in lymph nodes like subbulge. Then we usually take small steps. Then these tips are explained in combination with the surgery video. So we're going to move on to the neck and abdomen. Do it in the abdomen. I'm standing on the left side of the patient. It is very advantageous to stand on the left side of the patient. Then we will introduce it to you at that time. And at the same time, throughout the operation. And some of them are a little bit different. That's what we learn in our daily lives. Share something with everyone. We do anastomosis in the neck. In addition, there are more manual anastomosis. If the patient's tumor is elevated, an anastomosis will be done. So what we did was we did retrosternal path reconstruction. So it involves the establishment of the poststernal tunnel. After we build the tunnel behind the chest, our tubular stomach goes through this sleeve in the posterior thoracic tunnel, doing a neck anastomosis. Then combined with our surgeries, I will introduce them to you one by one. So this patient had 53 lymph nodes removed. Some of those 53 nodes were therapeutically responsive. Then the rest have not been transferred. There was a therapeutic response. That means there was a transfer before. Complete remission after neoadjuvant treatment. In addition to the tumor itself, it has this outer membrane that invades the esophagus. Lesions belonging to 3. So this patient is in good remission. Surgical dissection. Final YP installment. The stage of the pathology is 3 and 0. So this is our regular chest X-ray for the first and third day after surgery. We see from the chest X-ray, the patient's lung fields are relatively clear. There's no inflammation. In addition, the costal diaphragm angle is relatively clear and there is no effusion. When I reviewed the CT 2 months after surgery, this is the CT report. In those 2 months, the patient has very little surgery and is recovering well. Both lungs are inflated very well. So here's a follow-up CT scan we did 3 months after surgery. So look at the expansion of the lungs very well. The path of the tubular stomach behind the sternum. It puts no pressure on the trachea or the lungs. So here's the case. Then let's explain our surgery video. The first 4 poke cards go into the chest cavity. We are still following the method taught by the seniors before. We did the venous arch first. That includes dissection of the lymph nodes adjacent to the right recurrent laryngeal nerve. Then I'm in the process of dissociating. It's to cut off the entire upper mediastinum pleura. At first we use electric hooks to draw the scope. But to the side of the right recurrent laryngeal nerve, we must remember not to use electric hooks. Recurrent laryngeal nerve has strong tolerance to ultrasonic knife. but the tolerance to electrical stimulation is relatively weak. So when we use electric hooks, recurrent laryngeal nerve damage is easily caused by electrical conduction. But when the ultrasonic knife is very close, it is also easier to preserve the recurrent laryngeal nerve. Then after the right throat is clean, we descend from the venous arch to free. Normally we follow from the back wall of our esophagus. Circle like this. After reaching the back wall, turn around and reach the front wall. So our entire mediastinal pleura is sliced open. Then proceed to free the opposite deep side of the rear wall. The whole process of dissociation, I use more hooks. Then my habit and experience is to think that the electric hook, it's faster. Secondly, the level of the electric hook is relatively clear. Mastering the strength is no problem for hemostasis. How many watts did you set? The electric hook is like an electric knife to me. I usually use a second gear 60 spray coagulation. And now it's dissociating on the anterior wall of the esophagus, against the pericardium and inferior vena cava. This is at the diaphragmatic angle, usually 111 lymph nodes. Now, this is a place that a lot of people overlook under the microscope. So what we need to do is to dissociate more completely like a robot. So there are no lymph nodes left after this place is free. We don't have fat tissue, especially for lower esophageal cancer. Be sure to pay attention to free. So now, the anterior and posterior walls of the esophagus are almost free. Let's get closer to the venous arch. Fully free this esophagus. And then we are going to amputate this esophagus in the chest. Now we are going to dissect the esophagus in the chest. The generally chosen location is under the venous arch, and especially where the tumor is. Usually on the upper edge of the tumor. If it is a more aggressive tumor, that's the lower edge of the tumor. Just don't cut into the tumor. We use an ultrasound knife to cut off the thicker blood vessels. It's usually done with an electric hook. And you leave the severed end of the esophagus. It's easier to dissociate. We looked at patients going through 4 cycles of neoadjuvant therapy. Edema is still more obvious. Now we're working on the inferior edge of the venous arch. We then proceeded to free on the venous arch. After the operation is done, it's also easy to leave the severed end of the esophagus over the venous arch. After mentioning, in fact, the esophagus is still relatively easy to free. Before the left recurrent laryngeal nerve was revealed, generally, there is no problem with using an electric hook. But if there is less tissue around the recurrent laryngeal nerve, especially when there is more adipose tissue, we try not to use electric hooks because the conductivity of the surrounding tissue is poor at this time. As a result, the electrical conduction of our nerve will cause more damage. Here we are sticking an electrical hook to the cartilage ring of the windpipe. The left wall is freed. So the purpose of this free zone is to get away from the border. In addition, cut off the supply blood vessels. The two-end penetration method refers to the thoracic parietal side of the recurrent laryngeal nerve first, after finding the posterior nerve free, and then from the start of the posterior nerve to the foot. Well, what are the advantages of this method? It's on the top of the chest where it bleeds. We press the little strips of yarn after we are free. So if we bleed freely down there, we press the yarn down and then free it up. This way the surgical field is cleaner. If we operate in a pool of blood, the first is easy to damage the recurrent laryngeal nerve. And secondly, there are other side effects. In this way, as the blood vessel next to the left recurrent laryngeal nerve is severed, the bleeding will be minimal. That's in the left recurrent laryngeal nerve region. Generally, it is no problem to stop the bleeding by compression. Now we're connected. After penetrating, the back can be completely cut off peripheral lymph nodes and soft tissue. We are going to dissociate the nodes in the 106 tibia group. We are looking at dissociating this lymph node under the venous arch that sometimes drifts. Venous arches will have a certain blocking effect, but it's not a big problem. After we get used to it, there is still no problem. Of course, if we cut off the strange vein bow, exposed vision would be better, but damage to the odd vein arch. How useful is that strange vein bow? We actually want to design clinical studies as well, but no good clinical endpoints have been found. That's based on how we feel. First, it has a better protective effect on the liver. Secondly, it has a certain impact on the incidence of this pneumonia. The pneumonia rate is relatively small in practices like ours. That's in the free 106 pull group. That is our lung group. This fall node in the NCC subgroup. When dissociated, it can also be further dissociated into 5 groups of lymph nodes. It's on the left margin of the aortic arch. It can also be applied through this part, so our next video is dedicated to it. We are in the Japanese esophageal lymph node grouping system. It's called group 113. That's how our lungs are divided. It is 5 groups of lymph nodes that can also be dissected. We are now free lymph nodes under our carina. Subcarina lymph nodes are prone to bleeding. So our experience is, the electric hook must walk slowly in small steps. Don't be drastic. Once bleeding, it will affect the speed. Then walking slowly like this is cleaner. The damage to the trachea is also easy to control. So underneath the carina, we see 107 lymph nodes has been freed. So now it's a left main parabronchial node. That's our 109 lymph node. These lymph nodes are the site of routine dissection. In this patient, we do not routinely ligate a thoracic duct. So in this patient, the front tumor is closer to the thoracic duct. Our prophylactic thoracic duct ligation. But remember that if there are patients with cirrhosis and poor liver function, try not to ligate the thoracic duct. No bleeding from the free part of the left recurrent laryngeal nerve. This is our group 107 lymph nodes. Also relatively clean. We put in the hemostatic material and then put in the esophageal bag. Blue for hemostasis. We suture the distal part of the severed esophagus. Ligation outside the body. This is equivalent to the esophagus at the upper and lower ends. There is a silk thread connected. It's good for traction. For poke cuts in our chest, we don't usually put a chest drain. Now let's flip it over and make an incision in the neck. The average neck incision is about 2 cm. 1.5 cm will do, but the incision in the neck is relatively loose during the dissociation process. It's going to widen that incision. That's because we pre-ordered the esophageal bag in advance. So our place. It is relatively easy to cover the esophageal bag. If you find the right clearance, you can find the esophageal bag very quickly. Then pull the esophageal belt out. That esophagus is then migrated out. There's a traction cord attached to the band we just saw. Then if the esophagus is not enough, you can continue to swim up. So if you want to reduce dissociation, the chest cavity needs to be a higher free esophagus. Let's move to the abdominal operation. For abdominal operation, we will punch 5 holes together. We fought at this place below the umbilical cord. The observation hole is the endoscope hole. I stand on the left side of the patient. So now I'm holding the ultrasonic knife in my left hand. Raise the omental right vascular arch with the assistant. And then we open up this omental sac. You can see the back wall of the stomach. The assistant picked up the back wall of the stomach. We then go on to stomach a short free. Now we have this short blood vessel for the stomach. A hemalout ligation. Not that there's a hard lesson to be learned, it's more reassuring to have it ligated. Especially some ultrasonic knives, different brands have different properties. So we do a vasectomy. This way we are more reliable. Now free to the diaphragm angle. The diaphragm angle is equivalent to the fat on the left side of the cardia. The lymph nodes must be completely free. I have a 3-way aspirator. Put on our gloves. I rely on positive pressure in the chest instead of negative pressure to drain our fluids and gases. This will not cause too much negative pressure in the abdominal cavity to affect our operation. It's also easier to drain blood and qi out of the body. So this device works well. The entire surgery becomes much smoother. I stand on the left side of the patient, which is very convenient to operate. Removal of lymph nodes to stop bleeding, and things like the distal part of our antrum. Then when we are free from the stomach, the distal end of the antrum needs to be freed. This will ensure that the incision in the abdomen is relatively small. Okay, after we pull it out, this is the traction line. It ties a 1-to-2 drain over the mesentery. Then pull from below. Our surgical proposal is also to suture the lattice hole. Stitching completely avoids hiatal hernia. And if we have a retrosternal infection, it doesn't cause traffic. And we're going to take the small exit drain. The tip of the drain. It's in the back wall of our cervical esophagus. Then appropriately extend the incision in our abdomen. This incision is almost 3 or 4 centimeters away. Very small, actually, just the size of 2 horizontal fingers. It's very small. I stick my 2 fingers in and it's full. Let's stretch the white line again. Okay, this mouth size is quite enough. Then why can you use this small bite? That is, our dissociation in the abdominal cavity is relatively in place. This patient is not too thin. This is a simple dissociation at the right antral end of the aortic arch. So this is actually a relatively early video. Now we have some improvements. Now, it's very important that we do the first cut of the tube. We usually cut horizontally. This will extend the length of our stomach tube by 2 centimeters. So in the end, the tube position we do is relatively long. After we finish the mesh, it is about 5 cm to cut off the tube position. Now we're going to do a full suture of the tube. As we walk the path behind the chest, so we do a full suture. No serous embedding. That's enough. Then we do a little sleeve cut on the big curved side, especially the shortening in our stomach. Naked this big bend, naked the tubular stomach. And then we do the big curve. The hemostasis of the broken end of this omental vessel. Now let's put the side of the tube. You attach a traction cord, you put it back in your abdomen. and they pulled out our incision case. We generally use an 80 incision protective cover. Now we do the ZIFWAT process. Do a posterior thoracic tunnel. We do a separation along the back of the ZIFWAT process. After breaking the muscle bundles on both sides, use the palm press. So this is a very small opening. The palm press plate looks a little bit, and the space is a little tight. Okay, so we start from the neck. My left index finger and bowel plate. A connection has been formed. After passing through, hand the traction wire up for pulling. Since the posterior thoracic tunnel is a relatively unobstructed tunnel, so it is very convenient for us to pull. We know that when pulling the mediastinal bed, sometimes there's resistance. Sometimes it has to be returned. Do the pulling several times. It won't be smooth after repair. And this is us doing a hand anastomosis of the neck. Let's sew the first row first. That's the suture between the epigastric lining and the epigastric lining. Then the manual matching method in our department is similar. Both end-to-side anastomosis like Director Lee Yong's. We are going to clamp the sides with trifold pliers. To do a layered anastomosis, the first is to peel off the outer lining of the esophagus. What's left is the mucosa of the esophagus. We do the second suture, that's suturing the muscular layer of the stomach to the outer lining of the esophagus. General suture 6-8 stitches. Then we transect the esophageal mucosa. And then we are going to make a similar incision in the stomach. Start suturing the esophageal and gastric mucosa. Let's first find all 3 stitches. Then do continuous mucosal full-thickness sutures. Is this absorbable thread? This is an absorbable line with 4 zeros. Then send the stump back to the stomach cavity. Do the embedded suture. The incision in the abdomen. It's only the size of 2 horizontal fingers. And we are going to put in the gastric tube and the nutrient tube. Because of the posterior chest tunnel we did, so we can ensure that our incision is relatively small. In this way, even if we put our stomach tubes and nutrition tubes, the pylorus is closer to the peritoneum, so we can still implant smoothly. We sew up the abdominal incision differently. We sew them intermittently with absorbable sutures, but not ligated. We then use long absorbable threads for continuous sutures. We don't have to suture the peritoneum. We sew the white thread. After we sew continuously, then break this knot and tie it again. So there's no incisional hernia after this double safe suture. It can be said that no matter how our patients cough, or the wound fat liquefies, and there will be no incision dehiscence. So this is our postoperative image. We just saw that. Review 3 months after surgery. We don't have a tubular stomach inside the chest. Then whether we are in the radiotherapy department or imaging departments prefer this approach. This is our entire review. So let's take a look at some of the accidents encountered during surgery and their treatment. So these patients have subclavian artery First we free along the gap. It's in the middle and lower esophagus, along the back wall of the esophagus. This patient, it bleeds more easily. We can see that the esophagus also bleeds from the adenomyosoma. But there's nothing wrong with bleeding in this place. So don't be nervous at all. After we bleed, it doesn't matter if you press it or clamp it down. It won't be a problem. Even if sometimes the bleeding is near the root of the venous arch, there's no way to cauterize. So this with Prolene. The adventitia of the aorta easily stops bleeding. There's nothing to worry about stopping the bleeding in this place. We can see that this patient has received radiotherapy and chemotherapy. The adhesion to the thoracic entrance is relatively tight before surgery. We are going to see this process of dissociation. I found that this part of the adhesion is particularly dense. We are aware of the bleeding site, but we want to cut it clean. So carefully dissociate against the venous arch. Release against our subclavian artery. This area is separated against the subclavian artery. We bleed in circles instead. What we thought was a relatively small branch at first, but it turned out to be a rupture in the subclavian artery. So where is the tumor? There is still foreign invasion. Retreat after radiation and chemotherapy. It's not easy to clamp, but the treatment of the subclavian artery, we also have some experience. When we first did esophageal cancer endoscopes, the subclavian artery is more convenient to handle, because the subclavian artery is supported, so it's very easy to oppress. Unlike some large blood vessels near the heart, you can't do compression to stop the bleeding. At this time, I want to do a thorough cleaning around the bleeding area. Expose the field completely. At this time, we went through compression to see that the bleeding was not too large. There will be more bleeding in a while, so the hemostasis of the inferior artery must not depend on its self-clotting. Make sure to do this exact suture. These are all parts of the original tumor tissue. It's just fibrous, resilient structures. Then continue to drift. Fully expose where we bleed. When this place was fused with the lymph nodes, now ready to suture with Prolene thread. Then we know where the bleeding is located, so we have to cooperate with removing the gauze and suturing. Look at the bleeding area and use this aspirator to compress. And here we can see the rupture in the vessel. The bleeding is very rapid under the mirror, but in fact, it is not so dangerous under KTV. Usually this kind of bleeding, we sew 2 stitches and 1 shrinks our needle. You can achieve hemostatic effect. Okay, now tie the knot. Once the knot is done, the bleeding is controlled. So esophageal surgery is more complicated. Bleeding in various parts is also not uncommon. Once you bleed, you must remain calm. In fact, under the endoscope, there will not be too many cracks. Normal compression can stop the bleeding. So after we hold down, then calm down and think carefully. Collaborate on MDT stage when necessary. It was the treatment of the bleeding just now. So this is a tumor of our esophagus and a tracheal adhesion. Now, we see this kind of surgery a lot because in our upper middle esophagus, especially the upper esophagus. In fact, the most common adhesion site is the trachea, especially the trachea membrane. Our adhesion on the aortic side. Sometimes the aortic boundaries are easy to distinguish, so don't worry too much. But the adhesion in the membrane clot, because the membrane is very thin, if you swim deep, you will injure the trachea and rupture blood. That's too shallow to cut more of the tumor tissue. So the adhesion of this membrane clot. Be sure to accurately determine its clearance. Even if we can't see it with the naked eye, but you have to imagine the exact gap. Let's look at where the anatomy is. Now venous arch and superior vena cava. That's the trachea. This is the esophagus. This is the spine. There's no boundary between the trachea and the esophagus. Can you follow the gaps to establish dissociation? This is where the tumors are bitten together. Then this is where we follow, because the tumor extends to the venous arch. Let's separate the venous arches first. This adhesion is also very dense. Venous arches are usually not cut off for such patients, due to the need for exposure to cut off the venous arch. Then the rest of the expanding part also has a receiving part, so we're going to cut out the expansion. We usually have two ends of the Chich vein arch. This entry point. After the two ends are cut off, even the adherent odd venous arch needs to be removed. Look, these are the ends of the venous arch. We all had excision, and that leaves us with the invaded venous arch to be cut away together with the tumor. After cutting the odd vein, better dissociation of the posterior wall of the esophagus, we can see that the back wall is also tougher. That's the cardiac duct that's also adhered. This is the bronchial artery. We see that the back wall is still good and can be separated. We saw damage to the chest ducts. A tumor like this, the thoracic duct needs to be removed even if it is not damaged. Then the thoracic duct is also clipped. So now it's under the bulge, right here against the esophagus. We are usually at this bonding site. Find a gap up and down. You can rest assured when you see the lymph nodes. It is safe to dissociate along the surface of the lymph nodes. So this is dissociating from our bulge down to the head. If the adhesion is very dense, no gap can be found. Let's bring it up again. This is the better way. Fully free the place where there is no adhesion up and down. Let's look at the adhesion. It's an organ and a vagus nerve, and some swollen lymph nodes. The occupied area is very lethal. . So let's do the artery. This is where the tumor and the windpipe are. There's still a gap in our subclavian artery. Okay, here's an artery search. There's a gap. It's still this foot of the esophagus. As long as there is a gap, continue to drift. Outflank our most strategic areas. He has more lymph nodes. So this is the back wall of the esophagus. Rear wall invasion can be put in the esophageal bag. It's easier to pull our esophagus. It's easier to expose. Let's see the gap between this place. This is a fatal position for tracheal adhesions. We can't see the video very clearly, but we need to accurately grasp the gap. Ultrasonic knives don't work well here. We usually use electric hooks, blunt and sharp. If there is no gap, burn a gap with an electric knife. So we see tumors without any gaps, completely violated together. If you don't have radiation and chemotherapy before surgery, the surgery is much more difficult to perform, the radical resection. We look at the tumor and the tracheal space. This is the most dangerous part. At this time, if there is no gap, it is up to our judgment. So you have to draw a gap in your mind. This is at our senior level in oncology. That's near the inferior left artery. We are going to cut off some of the surrounding tissue involved. Okay, so this is where the top of the pleura is. Now you can see that the mesenteric artery is not invaded. It has been completely peeled off. Tumor tissue and surrounding spaces. Some normal loose gaps have been seen. After we found out that it was the left recurrent laryngeal nerve. In fact, each set of nerves below can be cut. We want to completely remove. Then you have to gradually find gaps from normal tissue. These suspicious organizations. I want to cut it off separately and send the pathology. And look at this tightly bound margin and see if that's the tumor. It's also some retracted fibers, fatty fibers, connective tissue. We can see that the upper and lower parts of the esophagus swim away. But it adheres very tightly to the trachea. There are no gaps. So at this time, according to the shape of the upper and lower esophagus, to find this gap in our minds, we see a little bit of a gap here. If you go up, there is no. So the line is the vascular tracheal sulcus in our mind. On the one hand, it is judged by combining the shape of the upper and lower bronchi. That would, in principle, damage the tumor. But try not to damage. Because after you damage the tumor, after cutting off the large pieces first, small ones can be cleaned up again. But after you damage the trachea, if you sew and cut again, it will not be easy to cut it clean. We've swam away from the esophagus completely. I'll see the whole picture after wandering later. Here we are on the side of the airway. Some remnants of this scar tissue. So the scar tissue is also tumor tissue. It's also our retreating fibrous tissue. We sometimes do surgeries and tell families it's palliative resection. The recovery is not good, but the pathology is instead zero. Has achieved complete remission. So is this patient. You see, we still have remnants on this side of the trachea. Then we use an electric knife to fully coagulate. Well, based on our experience, if it is a simple trachea invasion, even if there are remnants on the side of the trachea, then we can still achieve an 80% one-year survival rate after surgery. That's because the patient had already done radiotherapy and chemotherapy before surgery. So even if there are remnants of this place, and the chances of radiation after surgery are not that great, so the remaining part of the tumor fully coagulate with electric hooks, high temperature for anti-tumor effect. So in these patients, what they do is they get rid of the tumor.